Hello friends, this discussion is about Aiims protocol of COVID-19 management, which was published on 3rd August of 2020 in Aiims Bhubaneswar. There is also an updated version of the algorithm which was given on 8th of September 2020, which I will be displaying at the end of this discussion. As we all know that the forthcoming exams will be concentrating on the COVID chapter, and particularly institute exams, mainly Aiims exams, will be concentrating on the Aiims protocol. And you can expect questions in all topics like starting from the biomedical waste management, then the drugs which are being used, their doses and contraindication, a little bit of, then the scoring system of the patients, then the discharge criteria, and guidelines for home isolation after discharge, then about the oxygen delivering devices, and about the procedures of awake pruning which is being followed in Aiims. So in different subjects of anesthesia, community medicine, pharmacology, everything, questions can be expected in the forthcoming Aiims examinations. And this discussion I'm displaying directly from the PDF which is published, and this discussion will be very concise towards only the exam point of view. And 1 week before the Aiims examination, 1 or 2 weeks before the Aiims examination, I will be also uploading a summary kind of video of the same PDF. But however, for the time being, we'll be looking into this. I'm displaying it directly from the PDF which was uploaded. Initially there will be some kind of administration part which are not important for exams. This is about the wards in which the patients have to be admitted and all. We need not concentrate on that. The job responsibilities of different people also we can guess. There is nothing to study in this newly. This is the pro forma which is attached for every patient case files. Our discussion will start from here, that is the early warning scores for COVID-19 infected patients. Looking detailedly on that, this is actually the scoring system. As we all know, the Aiims exams will be concentrating on this scoring systems. If you see the previous year question papers, you can see questions being asked regarding the scoring in subjects like surgery, pediatrics and medicine. So I think this is also an expected question in the Aiims forthcoming. The parameters which are included are age, respiratory rate, oxygen saturation, any supplemental oxygen, systolic BP, heart rate, consciousness and temperature. In this, easy things to remember are age, oxygen supplementation and consciousness. See, age, if it is more than or equal to 65, it is 3, and if it is less than 65, it is 0. And supplemental oxygenation, if the patient is on oxygen, then he will be given score of 2, and if no, it is 0. And consciousness, if he is alert, it is 0, and if he is having anything like drowsiness, lethargy, coma, confusion, he will be given 3 points. And the other things I think that you will not remember when you see it for the first time, so it is better to see it 1 week or 2 weeks before the examination in detail, the other things. But we have to at least remember what and all parameters are being used for this scoring system. Okay, you can take a screenshot or anything and save it for future use. I will be like telling everything detailedly, and methods to remember it easily also I will be telling it 1 month before the examination in my summary video. and after calculating the score we have to find out whether the patient is coming under what risk grade. Okay, if it is 0, then the patient needs 12 hourly monitoring. Then if the score is between 1 to 4, it is low risk, a low warning level, 6 hourly monitoring. Then if the score is 5 to 6 or 3 in 1 parameter, this is important. Okay, this is an highly expected part of question. Okay, if the score is 5 to 6 or 3 in 1 parameter, okay, then the grade is medium grade and orange warning level, and monitoring is 1 to 2 hourly monitoring. Then if the score is more than or equal to 7, it is high risk, high grade, and the warning level will be decided whether if the patient is having any comorbidities like irreversible end stage diseases or any malignancies or brain injury or malignant organ failure, then he will be given black category, and if he is not having the above mentioned comorbidities, then he will be given red category. Okay, this is this tabular column. Then we are going into the treatment protocol part. After categorizing the patient, we will be deciding the treatment protocol. Okay, if the we'll be looking one after one, and I have highlighted the points which are like easy to remember, easy to click on the answers. And for the first time, if you are going through, it is better to read all the things. Okay, if it is asymptomatic, then nil oxygenation and nil medications actually, but you have to advise them to take things like vitamin supplements and calcium supplements, but no medication is advised as such. Then if the patient is coming under mild severity, then he'll the symptoms which he'll be having would be fever, cough, sore throat, nasal congestion, malaise, headache, no dyspnea, and saturation will be more than or equal to 96% room air. Okay, here you have to remember that no dyspnea part. Okay, all this headache, fever, mild symptoms will be given mild category, and investigation will be like routinely CBC, RFT, LFT, and ECG will be taken in high risk groups like elderly people and already hypertensive people, those kind of people. And medications, it is actually paracetamol, SOS, and we have to monitor the temperature of the patient. Then if he is having increased fever or it is not subsiding with paracetamol, then you have to start with HCQ. Okay, HCQ 400 mg BD will be given on the first day. Okay, then it will be changed to OD for the next 4 days. So HCQ totally 5 days we are giving. First day we will be giving 400 mg BD, then the next 4 days we will be giving same dose 400 mg, but OD we will be giving. Okay, before starting HCQ, we have to see for the ECG of the patient. Okay, if the ECG is having QTC complexes less more than 450 per millisecond. Okay, the only thing you have to see in the ECG is QTCs. If that is more than 450 per millisecond, then it is contraindicated to start HCQ, or else you can start. Then even on giving HCQ, if it is not subsiding, then you can consider favipiravir. The doses of favipiravir we will be discussing later on. Okay, and we have to shift to ICU if there is progression to the next stage. Next stage, there will be symptoms of mild disease and or pneumonia, that is chest x-ray finding, and respiratory rate will be more than 24 per minute, SpO2 of less than 94 percentage in room air. Okay, and this SpO2 by fraction of inspired O2 and PaO2 by FiO2, it is less than 315 and 200 to 300, and the person should be having no confusion or altered sensorium, no hypotension and all. And in this we have to see the routine COVID workup like CRP, D-dimer, ferritin, PT-INR, APTT, fibrinogen, LDH, CPK and all. Okay. And oxygen therapy, we have to target the saturation at 92 to 96 degree, 92 to 96 percentage, and it will be 88 to 92 percentage in COPD patients. And the oxygen delivery should be through non-rebreather mask if nasal cannula used. Non-rebreather mask, and if nasal cannula is used, then N95 or surgical mask should be applied over it. And we have to consider awake pruning in the patients with hypoxemia if no contraindication. This awake pruning will be a new term for some, and I wanted to tell a little about this awake pruning. This is that awake pruning. It is nothing, very simple. We have to lie on the four directions. That is, you have to lie on the right side for some time, then sit up, then you have to lie on the left side, then you have to lie on your abdomen. The same thing you have to continue. Okay, this is actually this is the awake pruning, and this is recommended for like each position for 30 minutes to 2 hours, and the patient must be able to notify to the staff, and the patients should use restroom prior to initiating this procedure, and frequent checks on patient every 30 minutes should be there, because if some patients will be on a nasal cannula or O2 mask, and while he is doing this procedure, if he is if his O2 connection is discontinued, then his saturation will fall. So monitoring should be there every 30 minutes. And exclusion criteria for this are those with O2 saturation more than 90, and patients unable to tolerate, and if patient is altered or unable to call for help, or if there is any hemodynamic instability, we have to actually not recommend this procedure. And this is the thing for O2 saturation maintenance. First we have to give through nasal cannula to 6 liters till 6 liters. If ideal O2 saturation is less than 90, then you can change for face mask. Even if it is not improving, then you have to go for nasal cannula plus face mask. Even if it is not increasing, then you can go for high flow nasal cannula. Then you can for alveolar recruitment, you can also add awake pruning. Even then, if it is not improving, then you can think of non-invasive positive pressure ventilation. Even then, if it is not improving, you have to go for intubation. Okay. And regarding the O2 delivery devices, the low flow devices are nasal cannula, simple face mask, tracheal mask, partial rebreathing mask with reservoir bag, and all these are having variable performance. And O2 flow rate also you can see in this. And oxygen delivery is actually maximum for high flow device like high flow warmed nasal devices. Okay, they have O2 flow rate of 10 to 40 liters and delivery is 40 to 100 percentage, which is not there with any other thing. But the non-rebreather type of mask with reservoir bag is also having a very good percentage of O2 delivery of about 60 to 90 percentage, and the O2 flow is 8 to 10 liters. All this tabular column and this flow charts are also taken from Aiims protocols, and I have segregated for the exam point of view. Okay, coming back to our PDF. We were seeing the moderate severity part. In that, the treatment includes LMWH, that's enoxaparin, the dose will be adjusted according to the D-dimer levels. And we can also try some steroids like IV methylprednisolone or dexamethasone, and HCQ can also be given for them also. And in this moderate severity people, you can also try for the investigational therapies like Remdesivir and convalescent plasma. About the dose of Remdesivir and the contraindications I will discuss later. Actually, for Remdesivir you have to see the LFT and RFT and then start Remdesivir. For this severe category, they will be having respiratory rate of more than 30 per minute and saturation of less than 90% in room air. They will be having this two features, or hypotension or drowsiness or confusion. Okay, you have to note that all these points are or. So even if you have any one of these features, then you have to tell them under severe category. Okay, investigations are the same with some extra blood, urine culture and those things. And a treatment part is they have to be maintained, managed in ICU only with high flow oxygen devices through non-rebreathing mask. We saw na non-rebreathing mask has high O2 delivery of about till 90%, so that is mostly used in ICU setup. And the treatment includes non-invasive ventilation or some ventilation intubation, which is decided on patient condition. And some investigational therapies like tocilizumab can also be used. And in this, the high risk groups are age more than 60, some say 65. Then those having with comorbidities like cardiovascular disease, hypertension, diabetes, immunocompromised, chronic lung, liver, kidney disease, cerebrovascular disease and obesity, BMI more than 25 kilogram per meter square. Now we are seeing the dose and contraindications of the drugs. Okay, there is nothing very big or complicated in this. Most of the things we have already discussed, I think. HCQ dose is 400 mg BD on day 1, followed by 400 mg OD on the next 4 days. And we have to see the ECG. I told na QTC you have to see. If it is if in the ECG, if the QTCs are more than 450, then we have to actually not recommend HCQ. Okay, for HCQ you have to see ECG. In ECG you have to concentrate on QTC complexes, and if they are more than 450 per millisecond, then HCQ is contraindicated. That's all. And some other common contraindications are known hypersensitivity, pre-existing retinopathy, children less than 12 years, pregnant and lactating women. In the protocol it is actually given QTC more than 500, but even for exam point you keep in mind 500, but for practice, even if it is more than 450, the practitioners are advising not to give HCQs. Okay, but as far as exam is concerned, you remember it is 500. Then favipiravir also, the first day we will be giving 1600 mg BD. Okay, this also comes in tablet form. HCQ is also tablet form, I forgot to tell that. Then favipiravir loading dose is 1600 mg BD followed by 600 mg BD for the next 1 week or to 2 weeks. That is decided according to the patient condition. And anticoagulation therapy, absolute contraindication is platelets less than 2 lakhs and relative contraindication is platelets less than 5 lakhs per millimeter cube. Then other contraindications include some bleeding conditions like brain mets, major trauma recently, major surgery within past 2 days, or any other bleeding in the past 2 weeks, endocarditis, severe hypertension like 200/120. If the BP is more than that, then this therapy is contraindicated. I think this is not new, this is already known. And the same thing for enoxaparin, which is low molecular weight heparin. Injection form subcutaneously we will give. And fondaparinux, this is actually not very commonly used, but this also has the same contraindications. And extra, it is contraindicated in those with creatinine clearance of less than 30. Heparin also, if the patient is having any history of heparin induced thrombocytopenia, then it is contraindicated. Remdesivir, this comes in injection form, and the loading dose is 200 mg IV single dose on day 1, followed by 100 mg IV OD for 4 days. And as I said earlier, we have to see the RFT and LFT before giving remdesivir. The creatinine clearance, if it is less than 30, we have to stop it. Pregnancy, it is contraindicated. And AST bar ALT, if it is more than 5 times elevated or more than 3 times elevated with any symptoms of hepatitis, you have to stop it. And one more thing to remember is that you should not give HCQ and remdesivir at the same time, okay, because they have some drug interactions. They are actually opposite to each other. So you should not combine HCQ and remdesivir at the same time. If you are starting remdesivir, you have to stop HCQ. Then tocilizumab, it is 400 mg IV stat single dose. Dexa, it is 6 to 12 mg according to the patient, and it can be given maximum till 5 days. Same with methylprednisolone, and these steroids are contraindicated in case of any fungal infections. Then awake self pruning, I told earlier that flowchart, that diagram which we saw na, that one. Any patient with ARDS is a candidate for this, and the mechanism is that this procedure will improve the ventilation perfusion mismatch. The contraindications we already saw, okay. It is the patient's comfort level. If the not comfort level, I should say, the patient's condition, like if he's having any increased intracranial pressure or increased abdominal pressure, and obviously pregnancy, 3rd and 2nd trimesters, GCS less than 8, that is if the patient is in coma, and if the patient is extremely obese, or if he has any chance of cervical spine injury, or if he's having any injury in his abdomen, chest and face, so that he could not perform this, that and all you have to contraindicate, okay. And we saw earlier that prior to the pruning, the patient should go for toilet. Then it is better to have reverse Trendelenburg of the bed. And you have to educate the patient about any discomfort in between the procedure. He has to inform the nursing staffs. And there is nothing much for exam point of view. This is just for those who are practicing. You can take a screenshot if needed. And the time spent in pruning, okay, the ideal duration of this is actually 16 hours, that is 4 times 4 hours each day, okay. And when to stop awake pruning, we already saw, okay, that is that contraindications. Okay, discharge criteria. This table column will be actually confusing. There is an algorithm kind of thing which is coming up, that will be more easy for us to retain the matter. This is the discharge checklist. This we need not know. Yeah, this is the discharge policy. See this, the same thing will be given in this tabular column and in this algorithm, but this algorithm will be much easier, okay. For discharge policy, any case, if he is very mild or pre-symptomatic, we have to discharge after 10 days of symptom onset, and he should not have fever for the last 3 days prior to discharge, okay. Then moderate cases, the fever should have resolved within 3 days, and the O2 saturation should maintain without any O2 support. Or if the symptoms are not resolved and if the oxygen is continuing, then we have to discharge only after all the symptoms are cleared and he is maintaining the O2 saturation in room air for 3 consecutive days. Okay, and if his symptoms resided at once, that is within 3 days of admission, then we have to discharge after 10 days. Like mild cases, you have to discharge after 10 days. And simple thing to remember is that we should have 10 days of hospital admission, and before discharge the patient should be afebrile and maintaining saturation in room air for 3 consecutive days prior to discharge. Okay, and for mild and moderate cases, important thing to remember that there is no RT-PCR test required before discharge. Okay, you can admit them for 10 days, and as this protocol you can discharge them as such without any repeat testing. But for severe cases, discharge only after clinical recovery, and the patient should be tested negative, okay, after the resolution of symptoms before discharge. And that's all about the discharge policy. Then this is non-exhalation or de-exhalation of care. This is also not important for exam point of view. This is the CPR resuscitation protocol. I don't think anything is important in this for exams. You can take a screenshot for future use. It is the same thing as our previous CPR protocol. The only thing is that you should not give mouth-to-mouth breathing. You have to use a ventilator using closed circuit and a filter for giving breath. Okay, you can take a screenshot and go through it. There is nothing new to learn it newly. This is the old thing. Okay, and in this, these and all are not for exam point. Yeah, we come to the biomedical waste management. This is very important for the exams. Like, I will tell you why. You will think that there is nothing new to learn in biomedical waste management in COVID, but there is small differences. I have highlighted only the things which we will forget or which we will get confused with. Okay, those things I have highlighted. If there is any question regarding biomedical waste management in COVID, there is high chance of playing with the language of the question, so read the question thoroughly before attempting these kind of questions. Okay, see, in biomedical waste management, see, for general waste, that is black bin, these things, the black dustbin should be used only for the people who are like working there. Okay, any item which were not contaminated by the patient secretions or body fluids, that should be put in this dry black bin. Okay, and all the sanitizer bottles, hand rub bottles, betadine bottles, everything which are not used at patient bedside. Okay, and in the yellow thing, this yellow thing and red are the most confusing things. In this yellow thing, we have to put all our mask, head cap, disposable linen, all those kind of things. Okay, and the blood bag, it is a good old question which is asked for years for confusing us. that is the same, that is yellow bag, and all the other things like sanitary napkins, diapers, and any item soaked with blood or body fluids, expired medicines, discard everything that comes under yellow. But the thing they wear will get confused is the goggles, face shields, the splash proof apron, plastic coverall, the nitrile gloves which we are using, and these things are those which will confuse us. These everything will be put in red bin, and these goggles can be reused after sterilization. Okay. And see, any leftover food from the ward by the staffs who are not attending the patients can be put in black bin, but all those things used by the COVID patient should be put in yellow bag. Okay. And gloves, everything comes in red. And all this pre-treated viral transport media, the media which they will use for taking the samples from the ward to the lab, that also should be discarded in red color bin. Okay. And this quarantine rooms, this everything is the old biomedical thing. So and this puncture proof container also, it is the same thing, so nothing new to learn in this. Okay, thus we complete with the biomedical waste management. And regarding dead body management, see, the thing, only thing which we have to concentrate for exam purpose is that if the dead patient is confirmed case or a suspected case, the sampling will be done before last handover. Okay. See, in this flowchart we can see that in confirmed case, if the if the death has occurred in isolation ward or COVID-19 ward, or he is brought dead, then whatever it is, if he is suspected or a confirmed case, first at the site of death you have to do a proper body packing in a closed plastic zipped pack which will be given, and then the dead body transport list, all that cause of death and those things should be filled up, and in the mortuary the dead body will be handed over after test report of the nasal sample. Okay. In this sample, if it is positive or COVID-19 suspect but not tested, then you have to inform it to the state authority. Or if it is negative, then you have to proceed with our normal thing, like if it is MLC you have to tell the police, or non-MLC you have to tell the relative. Okay. Okay, that's all. We come to the algorithm part. This is actually dated 6th of July, but there is another one algorithm which was given at the month of September, and this is the end of this PDF. So we will be finishing our discussion with that algorithm. See, this is the algorithm which was updated on 8th of September. This will be a gist of everything which we saw in this PDF. Okay. This at least this we should know before the exam. Okay. This is the very gist of everything. Okay. We will be going a little. Okay. In mild case, that is UTI without shortness of breath, that is the signs, then home isolation is recommended, or else in home isolation we have to do all that contact precautions, hand hygiene, symptomatic management, and HCQ after ECG, all the things we saw prior, and we have to watch for any extra symptoms. Okay, that's all. In moderate disease, any one of, that is respiratory rate more than or equal to 24 per minute, or saturation less than 94 on room air. Okay, we have to admit them. And O2 support, we saw the target O2, that is 92 to 96%, and 88 to 92% in COPD. And oxygen delivery device preferred is non-rebreather phase mask, which is having maximum O2 delivery. Then awake pruning, a detail of that we saw. Then antiviral therapy, we can give either remdesivir or HCQ. These two should not be combined at the same time. And convalescent plasma may be considered, but at present there is a big dilemma going on whether it is effective to give plasma or not. So before exam, I think there will be a conclusion in this. Any other updates, I will be giving it in the video. And anti-inflammatory steroids can be given, anticoagulation, low molecular weight heparin is given, and monitoring we should do for the work of breathing, hemodynamic instability and O2 requirement we have to monitor, and all the routine parameters 3 days once we have to see. Severe disease, anyone of respiratory rate more than 30 or saturation less than 90. And in management, we have to consider for high flow nasal cannula or any non-invasive ventilation, or if it is not improving, we have to go for intubation. Antiviral and all, it is the same as that of moderate cases. Only thing extra is that tocilizumab can be tested for them. That also some dilemma is going on. And all the supportive managements we have to see. Okay. And all these moderate and severe cases, we have to look for the clinical improvement and go for discharge. And see, there is a small gist of things given regarding the drugs below. That is remdesivir, it is for moderate to severe cases. We have to rule out RFT and LFT. We have to see, that is creatinine less than 30 or AST/ALT more than 5 or AST/ALT more than 3 with symptoms of hepatitis. It is contraindicated. We should not combine with HCQ. Tocilizumab is also for moderate to severe cases. There will be significantly raised inflammatory markers like CRP and IL-6. And we have to give this for those who are not improving despite use of steroids. And before giving, we have to rule out any active bacterial infections. And the dose is 4 to 8 mg per kg, maximum 800 mg at one time. In NS, we have to dilute it and give. And convalescent plasma is also for early moderate disease. Okay, this thing can be asked. Okay, for convalescent plasma, they are telling that only if you give at the earliest, you will have some improvement. Okay, at the last stage, there is nothing to do with plasma. So plasma, it is indicated during early moderate disease. And here you have to see for the high risk, that is we saw already, that is age more than 60, and all the comorbidities and obesity are the high risk for severe disease. Okay, this is the most recently updated algorithm for COVID, and thus we end up with the discussion. I don't know, I think I have covered everything in regarding the expected questions in the Aiims, the forthcoming session. But I don't know, maybe this is a confusing, or some more updates can be added to this protocol, but we will be uploading a video at least 2 weeks prior to the exam, so that it will be a summary of all what we have discussed today and any new updates which are coming up. That's all for today's discussion. Thank you.